So, colleagues, I'll take you through the clinical management presentation. This is called COVID-19 Clinical Case Management. It is purposely labeled version 1, April 2020. Like I said, there will be a lot of changes. So we'll then number them version 2, 3, 4, 5 moving forward, depending on what knowledge do we get. If we get more knowledge, we always update this. So this presentation will take you through a short introduction, then we'll look at objectives while we're doing this. Short notes on epidemiology, clinical presentation, laboratory diagnosis, clinical management, and palliative care before we conclude. As we know, the World Health Organization alerted the world on the 31st of December 2019 to a cluster of pneumonia of unknown etiology in patient in Wuhan City in China. A week later, it was known as the novel coronavirus, which is also called as the SARS-CoV-2, which we now know that from the 11th of Feb. This then was coined as COVID-19 because it started in somewhere around November 2019 in China. So this presentation describes clinical care in and outside healthcare facilities for patients who are suspected or confirmed COVID. I use the term suspected here, but you understand in TB we don't say suspect, we say presumptive cases of TB. I hope we'll harmonize the language at a later stage. Now, in terms of objectives, we wanted to understand what is COVID. Just have a brief understanding, not really detailed, but sufficient enough to know what it is. You should be able to suspect and screen individuals, understand how this is diagnosed, how is it transmitted, familiarize yourself with clinical management, and be able to prevent the disease while you helping patients that are that you interact with, or any other people, because it's about everyone here. So we care about everyone, whether it's a patient or a colleague working in admin or a community member that you meet in the bus or so. It's very important to know how to prevent the disease. SARS-CoV is a beta coronavirus, which is closely related to SARS-CoV, which we know as swine flu, H1N1. We've known this and for a while. So it is a new version of this swine flu that we've heard about before. And this is a virus which is enveloped, is non-segmented, and it's an RNA virus. It is believed to have originated from the birds, but the animal that mediated transmission to humans remains unknown till today. Incubation period is around 4 to 5 days, but we know it can last up to 2 weeks. So on average, one infected person spread the infection to 2 other people. But we've noticed that since the lockdown in South Africa, it hasn't been really 2. We hope it stays like that, but it's below 2, which is a very good sign. But we can't say it's a victory yet, because there are more people that are getting contaminated, infected in areas that really have been difficult to contain this. So we'll watch the space, but for now, I think it's looking good. Now, in terms of clinical presentation, I wish to say that approximately 40, possibly 70% of all infected people are asymptomatic. They don't show any symptom. and it appears they are transmitting the disease, which is very concerning. But of those that have symptoms, 80% are symptom. 80% develop mild disease among those that are symptomatic. 15% of patients will develop severe disease with hypoxia, or rather mild to severe disease, and 5% will become critically ill. And this is really a problem that we really don't want to reach a point where you have a lot of your patients needing critical care. But it's a small number, although behind those small numbers are human beings, and we need to really be cognizant of that. Now, in terms of clinical presentation, what you see is that fever, cough are the commonest cause, of course, fatigue. They produce sputum, shortness of breath, myalgia, arthralgia, sore throat, headache, and chills are some of the commonest symptoms. But you could also have gastrointestinal symptoms such as nausea, vomiting, and diarrhea, but these are common. Now, the main route of transmission is respiratory droplet. So people who have the condition will let it escape through their respiratory droplets when they sneeze or when they sing. But of late, we've heard that even when people speak, they release some of the droplets that will fall down. And then when you touch a hard surface, apparently this virus doesn't die. Generally your bugs would die after some times when they fall on a hard surface or just on the floor. But it appears this one stays longer, and when you walk on it or when you touch it, then you now take your hands to your face or your mouth or nose or eyes, then you get it contaminated. But then when you perform aerosol generating procedures in a clinical environment, such as when you're intubating your patient, when you're performing CPR, or you nebulizing your patient because you want them to produce a good sputum for examination, So these are various procedures that could make one release some droplets that could then stay, for a few minutes, maybe in the air and spread to the person next door. But usually it's just happen as you are examining or performing that procedure, then the aerosols will jump straight to your face. Also, that's why the use of protective equipment is personal protective equipment is very, very critical in clinical environment. But everyone need to also do that. Stools are possibly a source of contamination, but it's not. But there's no evidence of sexual transmission to date.